everybody, to Reproductive Justice, Advancing Advocacy and Healthcare Access. Super excited to have everybody here tonight. I know people are getting off work. Some people are going to come in late, or some people may need to leave early due to time. But thank you so much, everybody, for being here. Slide. So if this is your first workshop with us, welcome. We're Repro TLC, formerly known as Midwest Access Project. Repro TLC improves access to comprehensive reproductive health care by training providers in abortion and miscarriage care, contraception, pregnancy options counseling, and beyond that. So I'm going to lean us into a land acknowledgement. So it is our collective responsibility to call out the genocide, coercive assimilation, forced sterilization without consent, stolen land, family separation, and forced removal of Indigenous people on this land. It is not enough to just call it out. It is also important to donate money, contribute to mutual aid, and call out white supremacy. There's also a link that I can drop to find out what native land you are on. I will go ahead and pass it over to our amazing facilitator, Amber, to go ahead and introduce themselves and our workshop today.
Thank you. Hello, everyone. My name is Amber Barcel. I use she, her pronouns. Next slide, please. I have you can go to the intro slide. I have about 10 years of experience in the reproductive justice field, from teaching sex education and teaching peer sex educators in high school how to teach sex ed, to community education for Planned Parenthood in Nebraska. I've done some national and Seattle-based Asian American reproductive justice organizing. I have been an abortion fund board member in Nebraska, and most recently have been doing domestic violence, adolescent sexual health, and LGBTQ plus rights policy advocacy. So quite the fun array of reproductive justice experience. I do want to give two disclaimers today: that I'm not an attorney, so I cannot give any legal advice, and I'm also not speaking on behalf of any organizations or institutions that I work for today. And just some facilitator transparency, Alyssa has so graciously offered to move the slides for me, so you'll be hearing me ask Alyssa to move them. And also, there might just be a little delay in me seeing the chat. Next slide. Today, this workshop will focus on the intersection of reproductive justice, healthcare equity, and social justice. We'll explore the current landscape of reproductive healthcare and advocacy strategies. I'm going to teach providers how they can deliver and advocate for equitable patient care while applying key RJ tenets. And lastly, we'll teach community members how to advocate for their own healthcare experiences and access. Next slide. Our roadmap today includes introductions. I'll go over Reproductive Justice 101, which will also include a history of reproductive injustices. I'll discuss the current landscape, give tips on advocating for reproductive justice, give recommendations to providers, tips for patients, share ways to get involved, and some resources, and then we'll have our closing with questions. Next slide. I would love to know more about you. So in the chat, if you could share your name, your pronouns, your role, your city and state, if you're comfortable sharing that. I'm just curious about your regions. And then tell me which animal best describes your level of reproductive justice knowledge. First, we have the hiding otter, who's like, I don't know anything, I see nothing, I don't know. We have the curious penguin, who's just dipping their toes in, curious. We have the student hamster, learning still, and then we have the wise owl, who knows quite a lot about this topic. So if you could share your name in the chat, your pronouns, your role, location, and which animal best describes your level of RJ knowledge. For transparency, I've been in it 10 years and I feel like the hamster. I'll let your intros keep flowing. I really appreciate seeing these. All right, so the person I want to bring into this space is a personal hero of mine. You may know her. I was fortunate enough to work at Planned Parenthood in Omaha, Nebraska, when Dr. Turner came out of retirement to become the affiliate's the new medical director. And she was someone who really lived and breathed reproductive justice who was deeply compassionate to staff and her patients. And she was also a fierce advocate. She testified at the state legislature. She eventually became the national board president of the League of Women Voters, and she retired again after the Dobbs decision. And then she unfortunately passed away last January. The reason I want to share and bring her into the space is because when I think of a medical provider who understood and applied reproductive justice tenets and was in the community and in the streets fighting for bodily autonomy at the same time, I think of Dr. Turner. Next slide. Just noting that there's a slight delay on the slide. Yeah, thank you for your patience. First, we'll dive into Reproductive Justice 101. I'll share the history of the term, why it's needed, and I'll also share examples of injustices. Next slide. The term reproductive justice was coined in 1994 in Chicago before an international family planning conference when 14 Black women saw the need to expand the reproductive rights discussion beyond abortion and the centering of white, middle, and upper class women and their families. They sought to address the historical, social, and economic factors that affect reproductive health. So reproductive justice combines reproductive rights and social justice, and it's rooted in the United Nations Declaration of Human Rights. Next slide. So based on that human rights framework, RJ, put simply, as defined by Sister Song, is the human right to maintain personal bodily autonomy, the right to have children, to not have children, and to parent the children we have in safe and sustainable communities. Next slide. A reproductive justice framework highlights the need for all people, particularly POC and LGBTQI people, to make reproductive choices free from discrimination, coercion, or undue governmental influence. It is distinct from reproductive rights and reproductive health. So I have some definitions up here. Reproductive rights involves protecting a person's right to reproductive health. Reproductive health involves the delivery and expansion of reproductive health care. And then reproductive justice uses an organizing framework to understand and root out reproductive oppression to achieve human rights and social justice. So when we prioritize and actually center those at the margins due to their immigration status, their class, race, gender identity, sexual orientation, or disability status, everyone else in the circle benefits, including those who have historically been centered. So when we use this framework, everyone stands to benefit because we are addressing the margins. Next slide. One foundational component of the reproductive justice framework is the understanding that historical reproductive injustices and current reproductive health disparities exist due to discrimination based on race, ethnicity, socioeconomic status, and gender and sexual identity. For instance, through the 1970s, physicians across the US used coercive practices to sterilize more than 60,000 individuals who are low income, disabled, or people of color. The US medical system is also responsible for using people's bodies for birth control experiments in Costa Rica and Puerto Rico, for example. The first large-scale human trials for the birth control pill were actually set in Puerto Rico in the 50s. At the time, it was one of the most densely populated areas of the world, and it was struggling with widespread poverty. So the inventors of the birth control pill thought it would be the perfect setting for their large clinical trials. And Puerto Rican women were told that the birth control would prevent pregnancy, but they did not know that it was a clinical trial, and they didn't know that it could have dangerous side effects. The doses used in this trial were much larger than the doses in pills on the market today, which led to side effects that were deemed unacceptable by Puerto Rican healthcare professionals. However, the concerns were dismissed, and many of the side effects were thought to be psychosomatic by those running the study. And 3 women died while participating in the trial, and their deaths were never investigated. And then in the US, birth control has been used as a coercive method to reduce rates of poverty by preventing rising birth rates in underserved communities. In 1927, the US Supreme Court upheld the state's rights to forcibly sterilize a person considered unfit to procreate, leading to the forcible sterilization of around 60 to 70,000 Americans. Hysterectomies in the South were given the name Mississippi appendectomies, as some women as young as 12 were told that they were getting their appendix removed, only to find out years later that it was in fact their uteruses. This disproportionately impacted Black communities. Additionally, Indigenous women in the US were forcibly sterilized from 1955 to 1976, with an estimated 25% of Indigenous people of childbearing age being sterilized. Some of these procedures were performed under pressure or duress or without the patient's knowledge or understanding. And the law actually subsidized sterilizations for patients who received their health care through the Indian Health Services and for Medicaid patients. So Black and Latino women were also targets of coercive sterilization in these years. In 1976, North Carolina Supreme Court upheld the constitutionality of involuntary sterilizations, asserting that the welfare of all citizens should take precedence over the rights of individuals to procreate, and that it was the duty of the legislature to preserve the race. I'm sharing more modern examples because the Eugenics Board of North Carolina and its involuntary sterilization laws remained in place until 2003. And it's important to know that a progressive state like California actually had the most aggressive program. And they sterilized over 20,000 people from 1919 to 1952 and accounted for more than 1/3 of the roughly 55,000 officially reported eugenic sterilizations nationwide. And then again, more recently, throughout the 1990s, state legislators introduced a wave of punitive bills targeting female welfare recipients and incentivizing them to obtain Norplant. And this would have effectively criminalized their independent and private medical decision making and disproportionately limited the reproduction of Black families in comparison to white families. You know, these are just a few examples of reproductive justices in the last century. Some of them are back, before the 50s and during, but some of it does go into the 90s. Admittedly, I did not learn about this history until I was a year or two. I did teaching community sex education at Planned Parenthood in Nebraska. I was actually working under a grant that provided free birth control methods to people under 24 years of age. And we were always encouraged, and there was no research backing this up, but the best practice at the time was to share about LARC methods first and then work your way down to the pill. And when I learned that all methods are equally effective and that when we talk about low effectiveness, it's more due to human error, that was something that I thought, why don't we give equal weight to all birth control methods? And I also mostly taught this education to Black and brown young people, many of them immigrants or second generation immigrants from the countries whose people were experimented on for birth control. And I heard from them that their grandmothers and their mothers didn't trust these methods. And that would become what the bulk of our conversation was actually about when it came to birth control. And my initial instinct before I really understood the reproductive justice framework was to say, like, I feel like your mothers and grandmothers are wrong. They don't trust the science. And I think what's needed here is some myth busting about what birth control actually does and how it works. And the more I learned about reproductive justice, I realized that what was actually needed was a structural understanding on my end as an educator and the providers who are, counseling on these birth control methods. So we know the history involved with these methods and the importance of options and accurate information. Next slide. Well, those were some examples, before the 90s. I also want to be clear that ongoing reproductive injustices continue today. So on this slide, I have that patients who are people of color still report being ignored or not believed when communicating life-threatening symptoms. And also people of color also report being humiliated, verbally abused, coerced, threatened, restricted to a hospital bed during labor, forced to birth without a companion, racially profiled for drug testing or referral to child welfare, forced into procedures, denied information and the opportunity to give or refuse consent, denied care and pain meds, and having police or hospital security called on them for acts of self-advocacy. Next slide. There are, unfortunately, multiple examples, even in the last few years, and they're primarily about Black women. And one current horrific instance is of Adriana Smith. There are a lot of stories about Adriana in the news right now. When she was 8 weeks pregnant, she went to the hospital for a severe headache. She was soon diagnosed with blood clots in her brain, but unfortunately, within hours of that first visit, she was declared brain dead. Now, under Georgia law, abortion is banned after about 6 weeks of pregnancy, and that ban also contains provisions that strengthen the concept of fetal personhood. It's a doctrine that holds that embryos and fetuses should be considered people and as such are entitled to full legal rights and protections. Doctors told Adriana's family the law requires keeping her alive to preserve the pregnancy. And now Adriana is about 22 weeks into her pregnancy, and the hospital plans to keep her on life support until August, early August, when they will deliver the baby through a C-section. Yes, her story is devastating. Monica, I've been struggling in how to even talk about Adriana. I can understand that a statement could take time as well. So her family had no say in this. This grieving family did not get to decide what happens with Adriana's pregnancy. Again, remember, RJ includes the right to have children, to not have children, to parent in safe, healthy environments, and the right to full bodily autonomy. They're being told by the doctors who are following this terrible law what to do. So all autonomy has actually been taken away, and it's at a devastating cost. Next slide. Okay, moving on to continue talking about the current landscape. In the US, state and federal lawmakers, presidential administrations, courts, the medical community, and schools have been complicit in multiple historic reproductive injustices. And as we've discussed, these injustices still occur. And unfortunately, physicians have no formal reproductive justice medical education to address them. Meanwhile, a wide range of reproductive health disparities continue to exist in the US, with higher rates of poor maternal health, preterm birth, and infertility, among other conditions being experienced by socially disadvantaged or marginalized people. So this map here is just, I think, just an easy visual to see where we are as of May 2nd or May 2025 with the status of abortion access in each state. And as you can see, the key at the top, the darkest red is illegal, medium red is hostile, not protected is orange, protected is yellow, and expanded access would be the teal color. I'm curious if you can share what color, what status your state is, if it's illegal, hostile, not protected, protected, or expanded access. Okay, Vicky's saying expanded, protected from Monica. New York expanded, Bella's saying. Wonderful, thank you for sharing that. That's great news. Next slide. So the map you just saw was a result of the Dobbs decision overturning Roe v. Wade, and now we are in our second Trump presidency. We are just 5 months into 2025, but I also want to be clear that Republicans in Congress and in state legislatures have been working to dismantle public health long before Trump took office in 2016 and again in 2025. But I will say that right now is the worst that I've seen since I joined the field about 10 years ago. It's getting harder and harder for you as providers to care for patients and for patients to even access care. While access has always been limited for marginalized people without transportation, without steady income or other means of support, those options are becoming even more limited and potentially unsafe. Next slide. The next slide includes some headlines that are just from April and May of this year. As I'm sure you've already experienced, Trump has withheld Title X funds, which helps low-income people access reproductive health care, like birth control and STI testing, but not abortions. Recent weeks have involved an intense fight over Medicaid funding, again, a federal funding source that supports low-income people. We know about National Institute of Health cuts affecting research and hospital funding. And Trump, who in his first term initiated the ending the HIV epidemic, swiftly moved to dismantle HIV funding in his first month in office. And this is after Congress worked to start trying to defund HIV programs about 2 years ago in our federal budgets. And we'll start to see the impact of those federal cuts in states by the end of this month if we haven't seen them already. I'm speaking specifically the HIV cuts. Next slide is a question for you. What else are you hearing from patients, friends, or family about how the current landscape is affecting healthcare access? And also, how is all of this affecting you right now? Parents aren't understanding how we even got here. I know a lot of people who are undocumented that are very concerned about accessing care right now. I'm hearing that it's difficult to keep up. Yeah. Anything else you want to share? Okay, if any other thoughts come to you, please add them. Otherwise, we'll go ahead and move on. Next slide. Okay, that was heavy. We talked about reproductive injustices, past and current. We talked about the current landscape, which is making people feel enraged and scared. I'm actually going to go back to the chat. Also saying, don't know how it will impact Medicaid. People are scared that we'll wake up and not have health insurance. A young person asked about abortion access in the future. Definitely a hard thing to talk about since it seems uncertain. Hopefully you get that grant, Alondra. And Alyssa's adding that providers have mentioned they can't keep up with the landscape and unsure what care they can provide daily. It's actually my job to keep up on the landscape. That's my full-time job as a policy director, and I'll admit that even I am struggling, and I get the updates all day, every day. So I hear you if that's a challenge. Thank you for sharing that. Well, now we're going to move on and talk about what individuals can do on the individual level and community level for patients and providers. I pulled some recommendations from a study of repro justice advocates and leaders. Most of them had worked in RJ for more than 10 years. 60% were people of color, mostly Black women. And I also pulled from a United Nations report on the elimination of racial discrimination in healthcare, which is led by reproductive justice organizations in the US. So I'll share some of those recommendations with you now for providers. The first two recommendations you've already started on today, and that is to have a foundation in the history of reproductive injustices. I've added links to my original resources, original sources for the recommendations, but I also have some supplemental resources where you can further your learning. We will we will not be sharing the slides, but we'll compile all of these links in one email for you, so you'll have access to that. And the second one is to understand the role of the medical community in perpetuating these injustices. Next slide. Next the next recommendation is to understand the complex interplay between individuals and their environments and emphasizing the interconnectedness of various systems influencing their lives and their decisions. This can be done through the ecosystems model is one way. If you've ever used this model, let me know. I'm a social worker by training, and we learned about this in the context of therapy for clients. So this theory suggests that individuals are influenced by multiple systems, ranging from their immediate surroundings to broader societal structures. On its basic level, there are generally these categories: individual, interpersonal, community, societal. And on the right here is the ecosystems model with examples of each level. So I'm going to read those out for you. On the individual level, we have knowledge, skills, and attitudes. On the interpersonal level, we have family, friends, social networks. I'll also include medical providers. Organizationally, we have schools, workplaces, religious organizations. Organizations can also be institutions, which could be your workplace. On the community, we have design, access, connectedness, and spaces. And on the broadest level, this says public policy, but I also call it the societal level. We have national, state, and local laws and policy, but we also have cultural attitudes in there. Which level, never mind, I already gave it away. I was going to say which level are you at, but I already told you. So if we apply this to healthcare, we could say that on an individual level, this would be a patient's beliefs, knowledge, or even their fears of a diagnosis or their family history. On the interpersonal level, we have healthcare providers. What can happen at this level includes affirming non judgmental care or not being believed by a healthcare provider or even potentially being coerced by a provider. They could also be influenced here by partners or family members. And an example under interpersonal level on the provider side, contraceptive coercion can be seen through those LARC first methods. This is what I meant when I shared my experience as a sex educator and realizing I should not be prioritizing LARC methods like IUDs or the implant. And providers should actually be de emphasizing LARC first counseling methods and instead should formalize and test open ended contraceptive counseling. Moving on to the organizational level, again, this can be institutional. So this is your workplace. This can affect patients by your hospital or your clinic practices or policies. Even the diversity of your staff impacts your patients, or the types of training your staff does or does not receive. Also, the resources at your clinic, like language access, or even what types of pictures and videos and who they're seeing represented at your clinic. The community level affects patients by whether they're feeling connected, and this can be through houses of worship, schools, work, but also local resources like the food bank, libraries, or LGBTQ centers. And that broadest category is societal or policy related. This level affects patients through laws and policies that determine what they can and cannot receive as far as services or information, what rights they do or do not have. And I said it earlier, but I'd add that on this level would be cultural norms and narratives. And this is where stigma can come in. And we know that stigma on the societal level absolutely affects individual decisions and disclosures about things like abortion status, not abortion status, like abortion history or experience or STI statuses. And then we know that laws are created based on stigma and not science, right? So thinking about laws that criminalize people based on their actual or perceived HIV status, that's why that societal bubble or circle can have such a direct impact on an individual. So as you can see, individual decisions are shaped by multiple interconnected systems, and providers, you can use this to assess the impact of these systems on your patient's well-being and other choices that address both the individual and environmental factors, and while fully understanding that you as a provider are placed within these systems. Next slide. The next recommendation is to develop structural competency. This is an evolution of cultural competency. It helps us grasp how structures such as food, transportation, access to healthcare facilities, and racial discrimination contribute to health disparities. Structural competency can provide the social context in which reproductive decisions are made. So using the ecosystems model that I just talked about, you can work toward structural competency on multiple levels. Unlike the last slide, I made this graphic, and I'm sorry it's kind of crooked, but I made that one. I take full blame for the look. But using the ecosystems model I just talked about, you can work towards structural competency on multiple levels. So on the individual level, this can look like awareness and self-reflection. That could look like something you do after this presentation. On the interpersonal level with patients, this includes patient assessment and care planning, as well as providing options while patients have autonomy over final decisions. For example, if a patient is having issues taking off work all day to get to your clinic, ask if telehealth is an option. If your patient shares they're feeling unwell because they do not have enough to eat, are you prepared with referrals with no to low barriers? On the institutional level, training at your clinic and diverse hiring. On the community level, it could be collaboration with community partners, such as local or state-based reproductive justice organizations, or even institutions of higher education that have researchers that work on these topics. It could also be people that are funding these projects that expand access in your local area or your state. And on the societal level, providers can be advocating for the laws and policies that provide more supportive structure for their patients. And ultimately, that would benefit all of us. Have you seen or used the ecosystems model or the structural competency before? Yeah, I'm seeing Deb shake her head now. All good. Okay, Vicky's saying yes. Abby's saying yes. Thank you. Next slide. And the last recommendation, based on, I'll just say the last recommendation, is to see your patients as the experts of their own lives and deserving of dignity, self-determination, bodily autonomy, informed decision-making, privacy, consent, and respect. Because a human rights framework and pregnant people themselves assert that access and survival are not enough. Next slide. In summary, the recommendations are to have a foundation in the history of reproductive injustices, to understand the role of the medical community in perpetuating these injustices, to understand the implications of racial, economic, and gender injustice or all multiple systems as central to a patient's well-being, to develop structural competency, and to see your patients as the experts of their own lives. My question for, next slide, my questions for you as providers are, is there any part of reproductive justice you're feeling challenged by with your clients, within yourself, or your institution? And what is one way you will support reproductive justice for your patients? So is there anything you're feeling challenged by? And what's one way you'll support RJ for your patients? Alyssa is offering that providers in past workshops have mentioned not having a lot of time with each patient to support them with barriers and resources. Yeah, time is definitely a factor. Even if that resource is a social worker within your clinic, or I don't know what other roles, like navigators, that can help with that. So you as a guest speaker will provide like evidence-based, reproductive justice-based information. I shouldn't say evidence-based, I don't know that for sure, but some people aren't into that term as much. You're providing reproductive justice based information, and the teacher who like actually hosts that class will have opposing views and then share them in class, which can create, yeah, I that has definitely happened to me. A lot of times it's like a male gym teacher. It drives me nuts, but thank you for sharing that. Okay, the other question is, what is one way you will support RJ for your patients that you that could be new for you? Deb is sharing that this is making her realize that we as clinic providers and staff need to educate our board on exactly what RJ means. Yes. Okay, keep thinking about the one way you'll support RJ for patients, and I'll try to remember to ask it again at the end. I feel like we mostly have providers in this space, which is great. And the next section is more tailored to patients, which is okay because you also are patients probably. And then it also helps you understand the education that I'm going to offer to patients, that people who will see this recording later, so you can help them advocate for themselves. So I'll move on to the patient portion, and it may just be observation, which is okay. Next slide. Feel free to answer this from your perspective as a patient, but what barriers exist for self-advocacy when you visit a healthcare provider? And what do you wish providers knew about patient advocacy and or reproductive justice? Alondra sharing, one way I support is providing one-on-one health education sessions and ask open-ended questions on the care they need. Oh, how you support RJ. If you're like me, my friends and I always talk about the reproductive health care we receive. It's like the one type of healthcare we're always talking about the most, because it's also like the most vulnerable and sensitive one for us. So what I'm often hearing is that time is a barrier, the time with the provider, and it sounds like that's a barrier on providers' end as well. What also people also struggle with is feeling like the provider really wants them to make a certain decision and they feel like they disagree and they're not sure how to disagree with their provider. Vicky shared, when the provider enters with a plan in mind without discussing with me or perceived judgment. Alyssa's sharing, sometimes it feels hard to self-advocate to providers when we're in condition to believe they know everything regarding our health. And not everyone has like full medical knowledge. So yes, relying on them, relying on them to know everything, and also understand they just may not. I work with young people. So a lot of barriers I hear about are just transportation, like just getting there is really hard. Understanding insurance, understanding payment and privacy and confidentiality are really big concerns that I hear about. How to ask for not having an explanation of benefits is a really big piece of the advocacy that I do at work. Great, we can move on. So some tips that I put down for patients are to, write down your questions before your visit and take notes during and after. To know the laws in your state for the services that you are seeking. Know if your healthcare institution is religious or fake. I say religious because there may be some limitations on regardless of what is legal in your state, there could be limitations on what they provide. And I also say fake because crisis pregnancy centers, also known as fake abortion centers, exist under the guise of, they usually will buy up a space that's right next to Planned Parenthood. They'll call themselves a women's health clinic, and the intention is to trick people. They'll offer sometimes STI testing into not ending their pregnancy. Do you struggle with crisis pregnancy centers in your area? I know a lot of you are in like expansive states. Abby, all caps, yes. When I worked at Planned Parenthood, there was a crisis pregnancy center right next to us. And before I knew about them, I assumed that they were health clinics until someone told me. Yep, Bella's saying there's one right next to their office. Monica's saying 100%. Oh, Alondra, one actually came to drop off flyers at their health center. They're nefariously involved with larger anti-abortion groups. And they also teach sex education. They teach abstinence-only sex education. They are often guest speakers in public schools. They testify at state legislatures to advocate for abstinence-only education, to oppose comprehensive sex education. Yep, spreading abortion pill reversal propaganda. Yeah, thank you for sharing that. Yes, abstinence-only education is very harmful. Okay, so to bring it back, just knowing if this clinic or this healthcare institution is actually delivering, factual, non-judgmental information. So I have something in here, a resource on how to avoid and spot fake abortion clinics, because I never fault someone for going there. It's so easy to mistake it for a reproductive health clinic. Okay, going back to tips for patients, bring a friend with the full understanding that they may ask your friend to leave the exam room for part of your visit. Next slide. Remember that you're never a burden as a patient, that they are there to listen to you and follow up with you. Ask as many questions as you have and ask them to repeat information if it's feeling a little over your head, if that was difficult to remember, or you don't really know what they just said. It's completely reasonable to ask them to repeat themselves until you understand what your options are, what your diagnosis is, and what the next steps are. It's okay to, I work with therapists all the time. It's like, it's okay to break up with your therapist. It's okay to break up with a healthcare provider. You can stop seeing them at any point. You can stop going to any clinic at any point. I know that's really limiting if that is the only place in your area, but just don't feel like you are tied to a provider because that's who you've been seeing or that's who has your health records. They have to share your records with whoever you go to next. And lastly, word of mouth is really impactful. So share your experiences that you had with a provider, whether they're good or bad. And also, I'll just stop there. But don't be afraid to share your experiences and to talk about the reproductive health care that you've received. And again, these are the same resources that were in the last slide. Okay, you can go to the next slide. All right, and this applies to all of us, patients, providers, facilitators. Like I said, educating ourselves on the history of reproductive justice, the current landscape, and patients' rights is a great point of advocacy. Sharing the information we learned today with friends and family, sharing your story with individuals, your community, or even lawmakers to affect change. Donate to reproductive justice organizations if you can. And for action alerts to stay informed on current asks, I have some examples here on the right. Next slide. Reproductive justice is about much more than abortion. Remember, the right to have children, not have children, full bodily autonomy, and the right to parent in safe and healthy environments. So when we talk about reproductive justice advocacy, I'm not just talking about birth control and abortion. So if we want to engage in advocacy around reproductive justice, whether that's on the policy level or just a community level, that can include protecting funding for services and healthcare clinics, expanding doula services under Medicaid, abortion and contraception protections, minors' access to reproductive health, including abortion, restoring midwifery care and providing doula support in communities of color, mandating comprehensive sex education. I usually don't love mandates, but I do love mandatory comprehensive sex ed. That is opt out. Ending abstinence only, also now known as sexual risk avoidance education, and defunding and closing crisis pregnancy centers or those fake abortion clinics. I'm really proud to say that I've worked on most of these efforts in multiple states, some of them being very successful, others being a long haul. Guys, I'm curious if you've ever advocated for those issues before. By advocate, I mean like community or societal, like policy level advocacy. That could be testifying, letter writing, op-eds, teach-ins. Monica said 100%. Yeah, the most valuable people to have on these issue areas are medical providers. The most, like many, like not the most, like patients, of course, are very valuable, but they really listen to medical providers. Let's say not all of them, but they value listening to medical providers for a lot of these changes. Some other advocacy topics to engage in that maybe aren't necessarily directly tied to reproductive health and rights. This is the step where you are more expansive beyond reproductive health and rights. Okay, so we should also be advocating for accessible transportation in your area, affordable childcare, and protecting Head Start. No ICE in hospitals. We should be advocating for LGBTQI non-discrimination protections. On the economic justice side, we should be protecting and expanding temporary assistance for needy families, also known as TANF. SNAP, which are food stamps. We should be advocating to raise the minimum wage in our areas, and we should be fighting for paid family leave. And as far as environmental issues, remember, this is like the ability to parent in safe and healthy environments. We should be talking about water safety, noise pollution, preserving parks, the increased risk of asthma for young people because of climate change. This is how we brought it to become about reproductive justice when we care about all this, when we are trying to address the racial discrimination within the child welfare system, addressing policing, gun violence. Reproductive justice is broad because it touches every area of our lives, right? Going back to the chat, Abby saying lots of teach-ins, canvassing, letter writing, phone banking. Alondra said, I recently signed up to call out fake clinics with Abortion Action Front, and I'm trying to organize a thank you letter writing to abortion providers at work. Definitely searching for more advocacy opportunities. That's great. Have you ever advocated for some of the issues that I just listed or that are on this slide? Vicky's saying yes. I've worked on most of this, less so on environmental issues, admittedly. That's like one policy area I'm less experienced in. Abby saying, yep, worked in child abuse prevention research, and lots of these topics were our primary focus. Yeah, Abby, I used to do domestic violence statewide policy in Washington, and I was surprised to learn how to okay, I was surprised at how much I had to learn about not only the courts and policing and child welfare, but also why did I have to become an expert on tax codes? Because Washington State was trying to pass a working families tax credit, which did pass, but I just thought I didn't know I'd have to be an expert on like housing and renter laws and taxes and all of it. Yeah, and Monica's saying we often include gender affirming care in our policy work. Absolutely, the same playbook that has been used to go after abortion rights is now being used and has been used for gender affirming care. So thank you, Monica. I'm so glad that your workplace is addressing that as well. If if you have worked on some of these issues, that is amazing. If you haven't, that is okay. I will say that I teach graduate social work students about policy advocacy in Seattle. And at the beginning of each quarter, I inevitably hear from students. Most of them are ones that work with clients who are doing clinical practice, that they don't have time for policy advocacy. And if you're feeling this way as well, I hear you. And knowing what you know now, what is happening in our country, I challenge you, if you are not already, to find one area, just one area, um, to advocate for. And it's as simple as signing up for an organization whose mission you're aligned with. Just sign up for their email list and respond to every action alert that they send out. That's all you have to do. You just have to like type in your information. It goes to your members of Congress, your state person, your city person. They may respond, they may not, but that's usually like my advocacy thing outside of my work for the week. For me, that's like the ACLU of Pennsylvania. I just do every action alert they send out, or 18 Million Rising, who does Asian American organizing. And that's all I do. So I'm asking you to please do something on the societal level to help address the issues that you as experts are seeing on the ground, and the issues that you have deep expertise in. So I challenge you, if you're not doing this yet, just pick one organization or one issue that you're going to start advocating for on the societal policy level. Next slide. This next slide includes some national reproductive justice organizations and some local ones in case you would like to know who to follow, where to get started, where to learn more. So some of them are like, Spark does national work, but they're based in Georgia. So a lot of their advocacy will be based in Georgia, but a lot of their education is for everybody. Sister Song is the reproductive justice organization. Nationally, they do a lot of national advocacy. They're based in Georgia, though, so sometimes they focus on some Georgia initiatives. We also have Sister Reach in Tennessee, Ivy Black Girl in Nebraska, New Voices for Reproductive Justice, which covers Western Pennsylvania and Ohio. There are many, many more. These are just the ones I knew off the top of my head. But like I said earlier, it's really, if you have the capacity to partner with reproductive justice organizations for more trainings for your clinic staff, they would be delighted to do that for clinicians in their community to be trained in a reproductive justice framework. Benefits everybody. So reach out to those organizations, and it's best to learn from the people and organizations doing RJ in your community and state, and of course our many national resources. Next slide. I know I threw a lot of definitions at you, but just remember that reproductive justice, put very simply, is the right to maintain personal and body autonomy, the right to have children, the right to not have children, and the right to parent children in safe and sustainable communities. Next slide. Even though I knew what I was going to talk about with the history of reproductive injustices and current reproductive injustices, including the story of Adriana Smith, I share the feeling that someone had expressed when they said that they were enraged. And if you felt similarly, good. So I want to bring back Dr. Deb Turner here and share a quote from her. We must use this anger as fuel for action. We will use our anger to fight in the legislatures, in the courts, and in the streets. We will not stand by as constitutional rights are stripped away one by one. We hold the power to create a more perfect democracy. Our rights are human rights, and we will continue to fight until the right to abortion, safety, and bodily autonomy is restored. Our lives depend on it.